Thank you so much for this incredible honor again. So let me see, where's my pointer? First, to begin with, here are my conflicts of interest, and they've been reviewed and determined not to impact my talk. So to begin with, let me share with you when I got this invitation, although I was unbelievably flattered, I was totally terrified. And I was terrified in part because I knew that I was standing on a stage that so many amazing people before me have talked to you from, but also because of the topic of sleep apnea and cardiovascular disease. And although once I had a tremendous amount of confidence that I understood the links, actually recent work has generated a fair bit of controversy. And this controversy is very well embodied in a recent draft from the Agency for Healthcare Research and Quality. And this report was based on a systematic review of literature, and to the dismay of many, concluded that there was not a substantive evidence to support a beneficial role of CPAP on health outcomes, and in particular, cardiovascular disease. Now, 3 of the key studies that were reviewed in this report were the SAVE study, the RICATSA, and the ISAC study. Each of these studies enrolled patients with coronary artery disease and moderate sleep apnea who did not have high levels of sleepiness, and randomized them to CPAP or usual care. And you can see the hazard ratios here are listed, the modest, and were not consistent with a significant improvement in outcomes related to CPAP. And of course, if you could see this cartoon, when each of these results were revealed, and I was around the room for at least one of the studies, the feeling was captured by these 2 scientists in the cartoon who are holding up their test tubes and saying, "What is the opposite of eureka?" And in fact, not only were we puzzled, but then in fact the field has started to question whether our research needs to be re-examined. And some of the hypotheses for the null findings were in fact related to sample size. So for example, the largest of the studies, the SAVE study of 2,700 patients, was actually a magnitude smaller than most of the large TIMI studies of cardiovascular disease. There was also concern that the right patients were not enrolled in these studies, that maybe it was a resilient group, and maybe by excluding the very sleepy, we were having a healthier population that was less likely to show benefit. Each of the studies, CPAP use was approximately 3 hours per night, so there was the obvious concern that CPAP itself couldn't prove its efficacy when it wasn't used through the entire night. And then most of the studies for power purposes use composite endpoints, despite the fact that there is evidence that the different cardiovascular outcomes, stroke versus heart failure, for example, may have different sort of responsiveness to intervention. And then finally, this report in particular called out our favorite metric, the apnea-hypopnea index, and questioned, as many of us continue to question, whether this is in fact the appropriate measure of risk or even physiologic impairment. So when we think of the AHI, first of all, it has clear-cut utility, usefulness clinically, but we also know that as a simple count of the number of combined apneas and hypopneas per hour, it can't possibly describe the complexity of the disorder or disorders known as sleep apnea. And in fact, in thinking of the AHI, it occurred to me that maybe there's a bit of an analogy of trying to force our patients to be described in such an inflexible way. And it really sort of raised the notion that perhaps this is somewhat like the fabled Procrustean bed, where Procrusteus amputates people who are too tall for a bed or stretches them if they're too long. And in fact, as we think about the tools we need to identify disease in a way that we could tailor our interventions to meet the physiologic abnormalities, we're reminded of the goals of the precision medicine initiatives. And in fact, from the Precision Medicine Institute, a very simple saying is, you wouldn't wear just any pair of glasses, your prescription is tailored to your vision. So is that AHI really providing that prescription we need to create the right lens? So what I will now, with that introduction, I'm now going to very briefly review some of the physiologic consequences of sleep apnea that we, understand to increase cardiovascular risk, but particularly emphasize the limitations of our current diagnostic strategies, especially when they come to diagnosing and managing women. I'm also going to spend most of the talk talking about the many contributors that result in sleep apnea actually being a heterogeneous disorder, or as I hinted at before, potentially several disorders. And that may impact the susceptibility to cardiovascular disease, the response to treatment, and I'm going to highlight some emerging tools that may allow us to better phenotype sleep apnea. And finally, I will conclude with some gaps in the AHRQ report that we might be able to address. So briefly, physiology. For this audience, I just briefly note that I think it's well understood from the days of Dr. Bremer's work that obstructive apneas will cause a number of effects in terms of breathing against the occluded airway, causing negative pressure swings, not ventilating, causing hypoxemia, hypercapnia, responding to those stimuli with arousals and resulting in sleep fragmentation, and then ultimately resuming breathing and resaturating. And in fact, that desaturation, resaturation creates that intermittent hypoxia stimuli, which we know can stimulate multiple adverse metabolic problems. Now, in this particular diagram that Shirok Javahiri created in a review article, we also can see that there are multiple pathways that will lead from these cycles of apnea and recovery that lead to multiple cardiovascular outcomes, which include hypertension, heart failure, coronary artery disease, stroke, and arrhythmias. And these include pathways that revolve around the autonomic nervous system, oxidative stress, inflammation, as well as direct pressure around the heart or the transmural pressure gradients due to these recurrent Mueller maneuvers. However, as complex as I just described, that complexity doesn't even begin to address the variation in disease stresses that individual patients with all labeled with sleep apnea may experience. And in fact, any given patient with this label of sleep apnea may have marked differences in their doses, their nightly doses of hypoxia or sleep fragmentation. They may have very different genetic and other backgrounds that modulate their tissue and systemic responses to hypoxia, as well as other causes to modulate vulnerability. As just one example, we know that we think that we understand hypoxia as a key driver of sleep apnea-related cardiovascular disease. But as Gordon Mitchell and others have shown, is that in fact the effects of hypoxia may be quite different according to the dose. So on the one hand of the slide, we see that at very low levels or mild levels of hypoxia, you actually may get an angiogenic response resulting in collateral blood flow, which actually may reduce the size of a heart attack or stroke or, a vulnerable infarct size. On the other extreme, with more severe hypoxia, we do know that there's endothelial dysfunction, increase in peripheral vascular resistance, hypertension, and a number of adverse events. But you could see in the middle, where many of our patients lie, that the positive and negative results might tip both ways. I also would like to, especially talk to the clinicians in the audience who I know understand the heterogeneity of the condition in terms of clinical presentation. We know that there are many phases of sleep apnea. It occurs commonly in obese patients, but also in non-obese. It occurs commonly in the elderly, but also in children and in pregnancy. And some patients complain of this disabling hypersomnia, but others complain of insomnia. And the clinical variability is further emphasized across the spectrum of sleep symptoms. And for example, at any given AHI, one patient may complain of debilitating brain fog, whereas another patient at the same AHI will have no evident cognitive impairment. And we also know as clinicians that there are multiple potential risk factors, and that's led to the idea that sleep apnea may be a multifactorial disease with different contributions of obesity, anatomy, and physiology. Although I'll also like to come out with the notion that maybe it's not so much a multifactorial disease, but multiple diseases. And in fact, clinical variability will be influenced by comorbidities, as well as when you get the disease and how long it is before you're treated. Now, there's been amazing progress in us understanding some of those ventilatory control abnormalities, in part due to the good work of the many physiologists in the field, in particular moving, using polysomnograms to understand the underlying physiologic risk factors for sleep apnea. So here is a slide from Danny Eckert, who really emphasizes the point that although most patients with sleep apnea have some degree of impaired upper airway anatomy, in fact, about 70% of patients have one or more ventilatory or physiologic control problems, which include ineffective upper airway dilator muscles, which also include unstable ventilatory control mechanisms, which we often think about or label as loop gain, or what's called a low arousal threshold, which is the propensity to wake up during sleep in response to even a modest respiratory stimuli, and in fact during an apnea before upper airway muscles have the chance to fully dilate. So in other words, when we use that AHI, we are in no way beginning to address these multiple potential mechanisms, loop gain, arousal threshold, muscle responsiveness, or airway anatomy. We also are not capturing even features such as the individual or average duration of apneas or hypopneas, or their distribution over the night in terms of their REM predominance, their clustering, whether there's recovery time between events and between clusters. And in summary, this failure of the AHI does not inform about physiologic consequences such as sleep fragmentation, hypoxic burden, those pressure swings in the chest, or autonomic, specifically cardiovascular autonomic responses, all of which may be the pathways leading to cardiovascular disease. And even when I look back at our epidemiologic studies, and here's some summary data from the Sleep Heart Health Study, which is a study of over 6,000 individuals studied studied longitudinally to understand the relationship between sleep apnea and development of cardiovascular disease. And what you could see here in black are the summary hazard ratios for moderate to severe sleep apnea. In black, we have results in men, and red in women. And you could see in men, as we've reported years ago, that men have about a 50% increased risk of developing coronary heart disease, heart failure, or all-cause mortality with severe sleep apnea. And for stroke, it's actually much higher at threefold. But you could see null and potentially even protective effects in women. And again, I like to put forth this idea is that especially in women, we may not be picking up the sleep disruption or autonomic stresses that may also be driving cardiovascular disease. So let's now just again think more about the variation in physiology, genetics, and exposures that may moderate any given patient's sort of susceptibility to cardiovascular disease given sleep apnea. So physiologic findings may include, even baseline as well as responses of the autonomic nervous system, particularly how the heart responds to any given apnea or hypoxia. The other area that's been relatively under-recognized is genetics. We all know, all of us are worried about developing a heart attack, especially if we have a family history, and we know that there are multiple genetic risk factors that may predispose to premature cardiovascular disease. And in fact, those risk factors that in particular operate on pathways like inflammation or angiogenesis may moderate how susceptible we are to a further stress related to sleep apnea. And an area that actually feel is very been inadequately studied is how those lifestyle exposures, which we know are important for healthy hearts, may also either amplify or attenuate our susceptibility to sleep apnea-related cardiovascular disease. Also, sleep apnea is cardiovascular disease is a chronic condition, and yet we know very little about the relationship of sort of the age of onset, cumulative exposure of sleep apnea, and then these cardiovascular outcomes. And then, of course, other sleep disorders are quite common in addition, and they may interact with sleep apnea to impact cardiovascular disease. Now, this area of heterogeneity has been an area I've been really focused in and had in the last 10 years, and really have had the privilege of working with an amazing group of physiologists and geneticists at the Harvard Sleep Division who have really interacted in a really fun way. We were talking about having fun before. And this work includes work that's been led by Scott Sands, who in particular has been developing tools to describe those physiologic mechanisms that lead to sleep apnea, which we'll call endotypes. And then there's Ali Azarbin's work, where he's been actually extracting measures that may of sleep apnea, then predict cardiovascular disease. Andrew Wellman, who is looking at ways to personalize treatment based on the above factors I talked about, and a team of geneticists, including Tamar Sofer, Brian Cade, Hemingway Wang, and Sean Purcell, who have been looking at large genetic databases to look at how genetics may moderate risk. Now, one of my particular passions is to understand some of the gender disparities in sleep apnea, in particular, how we diagnose it and propensity for cardiovascular disease. And this approach for heterogeneity fits right into taking a gender-sensitive lens. And in fact, I have submitted that, in fact, looking at male-female differences is the first step to precision medicine. And again, the clinicians here know that when you look at a sleep study of a woman compared to a man, women appear to have more hypopneas, less apneas. Their apneas are shorter. There may be more arousals, but less hypoxia. There are more events relative in REM than non-REM. There's less positional dependency. And symptomatically, often women report less sleepiness and more fatigue. And these differences, in fact, were embraced by one of the patient groups I referred to before, and they work with the Society of Women's Health to create a fact sheet to empower women to have a conversation with their doctor because of the concern of under-recognition in women. But in fact, all these traits, the hypopnea suggesting a more collapsible airway, the REM dominance, et cetera, also suggest that the underlying mechanisms of sleep apnea may in fact vary very fundamentally in men and women. And we have been able to recently try to get a handle of some of this, again, because of Scott Sand's work. And what Scott has been able to do is to take his tools from controlled laboratory intervention studies to actually be able to extract from routine clinical and research polysomnograms measures of ventilation and flow limitation, and from those measures estimate those endotypic traits of loop gain, arousal threshold, muscle responsiveness, and so forth. And he showed that they correlate well with standard assessments, and they're highly reliable, they're consistent across the night, as well as even moderately reliable over many years. In fact, to some extent, as reliable, if not more so, than the AHI. And using those approaches and taking advantage of data from the multi-ethnic study of atherosclerosis and in work with Dr. Wan, we found that indeed those traits in women are those PSG traits very much are echoed by differences in endotypes. Women have a lower arousal threshold. They're more likely to wake up with any given respiratory stimulant. They have actually more stable breathing, lower loop gain, and they are less collapsible, explaining that higher ratio of hypopneas to apneas. And when we account for just these few factors, we could explain about 1/3 of the sex differences in non-REM and all of the sex differences in REM sleep. And the implications for these include that women may indeed have cardiovascular markers that differ than men. They may have less hypoxia, but more arousal. They may more likely report insomnia due to the low arousal threshold. And in fact, they may not be as tolerant to PAP if they're more likely to wake up. And in contrast, in men, have marked increases in collapsibility, ventilatory instability, as well as deficits in pharyngeal compensation. In fact, we're able to estimate that being a man had an effect on collapsibility that was 3-fold that of aging by 20 years. Now, we further wanted to ask questions about how these endotypic traits vary by some other factors. And just beginning to peel the onion, we looked at obesity, age, and background ancestry. And to do this analysis, we looked across 3 very diverse cohorts. One is the Mesa cohort, which is a multi-ethnic cohort of older individuals. The Mr. Oz cohort, a cohort of predominantly older men, and the Cleveland Family Study, a relatively young cohort. And what we found was that both increased BMI and increased age were both associated with increased collapsibility and increased loop gain. However, the obesity findings were largely explained by central obesity, but not by low lung function, suggesting maybe there was a pro-inflammatory release of cytokines related to visceral fat that might relate to ventilatory control. In contrast, we found that the changes in loop gain in older age was to some extent explained by subclinical cardiac and renal disease. We also saw interesting differences by ancestry background, and we found, in fact, that Chinese Americans, particularly in Mesa, had very high collapsibility, and that high collapsibility almost completely explained the elevation in AHI in that group. In contrast, amongst our African American samples, we found relatively favorable collapsibility and compensation, but higher loop gain. Now, why do we want to know this? For a couple reasons. One, as we mentioned, these endotypes may help direct treatment. So for example, and in this figure by Sharok Javaheri, it points out that those individuals with a small collapsible upper airway may benefit from targeted interventions like oral appliances or upper airway surgery. Those with poor muscle response may do best with, or do well with hypoglossal surgery. Those with low arousal thresholds, hypnotics, and those with unstable ventilatory control with oxygen. And if we go back to those population findings that I described about endotypic variation, here's some speculation. It may be that the older obese and male patients who have several endotypic abnormalities may be most susceptible to residual sleep apnea if you treat them just addressing their airway. You may also have to address loop gain. On the other hand, women with a low arousal threshold may actually benefit from medications that target that arousal threshold per se, like a hypnotic. And individuals with Asian ancestry may particularly benefit from devices that really address the anatomic risk factors for sleep apnea. But these endotypes now not only may inform treatments, but let's ask, do they also inform who develops cardiovascular disease? So to begin this section of the talk, I want to highlight the work of Ali Azarbin, who, as I mentioned, has been his focus is to develop markers from the PhD that predict cardiovascular disease. And this work starts with the notion that airway collapse may lead to two key responses important in heart health. One of them is sleep apnea-related hypoxemia. The other is the heart rate autonomic response. And to capture each of those, he developed two metrics. One is the sleep apnea-related hypoxic burden, which you can see here. And what this is simply a measure of the depth and the duration of hypoxia related to each apnea and hypopnea at night average. And the other measure is a measure of delta heart rate, which is really the average heart rate response to an apnea relative to baseline. And in fact, there is a relationship between Dr. Sand's endotypes and Dr. Azarbin's markers of cardiovascular risk. Individuals with higher loop gain have higher delta heart rate. People who are more collapsible have more hypoxic burden, and people with a lower arousal threshold have greater delta heart rate, greater autonomic responses. And but Dr. Azarbin's markers also very robustly predict cardiovascular outcomes across multiple cohorts. So here you see just some of his work just in the last 3 years, showing that hypoxic burden and/or delta heart rate predict outcomes across multiple cohorts, including heart failure, all-cause mortality, cardiovascular mortality, chronic kidney disease, hypertension. And in fact, these associations persist after adjusting for AHI. They are more significant than the AHI. Most of those associations are seen in both men and women. And in several cases, there is an interaction between delta heart rate and hypoxic burden so that those who have both exposures have the greatest risk. Now, what's also quite exciting is an article was just accepted, and this is an article that raises the question that delta heart rate in particular may be useful as a marker for risk stratifying what patients may benefit from CPAP. So in this work, we used the work of Dr. Yüksel Peker, who's the PI of that Ricazza study. So Ricazza is a study, one of those 3 studies I cited, of 244 individuals with, who had recently had coronary revascularization, were not sleepy, and were randomized to CPAP or usual care. And what you can see here on the left are differences in the incidence of cardiovascular disease in the overall cohort before we risk stratify them. And you could see the green line in green. You can see the CPAP results, and the red are the non-CPAP group. Now, what I want you to look at is what happens when we risk stratify. And when we look at that group here with an increase in the delta heart rate, you see a very prominent splaying of those survival curves, such that the CPAP group in green has actually a much favorable cardiovascular-free survival once you only look at people who have the increase in delta heart rate. And what's really somewhat perplexing and concerning is if you go to the middle graph, and although the sample size has to be taken with a grain of salt, in the group without an elevated delta heart rate, you actually see the suggestion of a reversal of a pattern, where in fact those treated with CPAP who actually have increase in cardiovascular mortality if in fact at baseline they did not have a brisk heart rate response to their apneas. And these analyses estimated that for each that individuals with a 1 standard deviation increase in heart rate responses above the mean, or 10 beats per minute, had approximately a 60% reduction in cardiovascular disease with CPAP. So this may suggest that this marker, maybe even more so than other markers we've talked about like sleepiness, may actually prove to be a promising risk stratifier. Now, I'll also like to mention that in addition to these relatively advanced markers, I also have been very much an advocate of having everybody look at the average apnea-hypopnea duration as another marker for risk stratification. And I just wanted to emphasize why I've been excited about this. One, it's readily available. It does reflect overall arousal threshold. It's a trait. It's actually genetically determined, and in fact has one of the highest heritabilities of each of our traits. In African Americans, we saw a heritability of 60%, and we found several GWAS significant findings. It also varies in the population. Women have shorter events, as do African Americans, particularly African American women. And moreover, when we go back to the Sleep Heart Health study and we reanalyze, and this time 11-year mortality, we actually found that those individuals who had the event durations in the quartile of the shortest events had an approximately 30% greater likelihood of experiencing mortality over this time compared to individuals with the highest event durations. And these associations were particularly interesting because they persisted, again, after adjusting for AHI, and they were seen in both men and women. So let's now, again, talk a little bit about gender differences. And sort of inspired by sort of maybe this respiratory event duration may be of interest, but there may be additional markers. My colleagues and I have done some work that's still in progress, but I wanted to share with you. We looked at about 30 different polysomnographic markers, both traditional risk markers, as your AHI, average SAT, et cetera, as well as some of these novel risks. And we used a machine learning approach called LASSO to identify a linear combination to create a summary score. And we used data from the Sleep Heart Health study for this. And what we identified was a summary score that was quite atypical from the usual scores that many of us would think of calculating. It includes several measures that I would say of autonomic responsiveness, meaning the mean heart rate to event, the mean heart rate related to desaturation changes. It also included high arousal intensity based on the amplitude of the arousal, but actually a low arousal index, suggesting maybe adaptation to arousal occurrence. It also included two symptoms, both insomnia and sleepiness, with insomnia having the stronger effect. And what we saw in women was that this score predicted new cardiovascular disease in women with an odds ratio of about 1.43. And in men, it did not perform as well with an odds ratio of 1.13, suggesting that maybe these emerging phenotypes of comorbid insomnia and sleep apnea Mesa may actually share some of these mechanisms that were captured in this particular score and that we need to think about clinically. Now, I'll also like to sort of identify the potential to not only use data from a PSG, but to use blood-based biomarkers. And for this work, I want to highlight Tamar Sofer's work, which, where she takes basically a causal chain perspective, trying to really attempting to link sleep traits like endotypes to molecular responses such as changes in expression or metabolite concentrations to clinical outcomes. Very simply, I'm going to show you one very preliminary example, more just to tease us all, is she's, in one study, she started out first trying to identify what are the optimal phenotypic or sleep study measures of sleep apnea. Number 2, how they relate to metabolites. 3, combine those metabolites to create a metabolic risk score, and then test that risk score as it predicts a clinical outcome, and in this case, diabetes. So in these analyses, very preliminary from the Hispanic Community Heart Study, here is the results of those steps. Number 1, just using a home-based sleep study, which was very limited in this cohort, she was able to extract 2 different dimensions of sleep apnea using a principal component approach. One dimension, principal component PC1, largely captured the hypoxia-related variables, and the second one, PC2, captured short events. And this was not hypothesis-driven. This was really an anonymous kind of machine learning approach. She then, to each of those principal components, she found which metabolites best correlated with them and created a metabolic risk score and tested the association with diabetes about 8 years later. And what we find is some very intriguing results. So what I'm showing you here is that the metabolic risk score that was trained for PC1 was actually predicted a 2-fold prediction of diabetes in the woman in this cohort. And when you just compare that to PC1 alone without the metabolic risk score, you could see that that odds ratio was much smaller at 1.3. And similarly, what you could see for PC2, when you train a metabolic risk score, you get a significant protective effect for long events with an overall hazard ratio of 0.6. And again, if you only use the phenotypes, that protection wasn't evident. So this is this work now we're trying to cross-validate it in other cohorts, but again shows the promise of a thoughtful approach to phenotyping with potentially considering both the hypoxia and the arousal or the event or the autonomic features separately, and then using blood biomarkers to improve signal. Now I'd like to go back to maybe just a comment too about other ways we could think about why given patients may or may not develop cardiovascular disease in relationship to sleep apnea. And I'd like to just give one example of a lifestyle exposure and one example of genetics. So the first lifestyle exposure is smoking. We know smoking is a big cardiovascular risk factor. It causes endothelial dysfunction. We actually also know from Sleep Heart Health and Cleveland Family that women have more endothelial dysfunction in relationship to their sleep apnea than men. So in some lovely work, again, from the Sleep Heart Health study, Luke Donovan tested the hypothesis that there was an interaction between smoking, moderate sleep apnea, and gender, and found that women who were active smokers with sleep apnea had a 4-fold increased risk of developing cardiovascular disease compared to male non-smokers without apnea, suggesting again that we shouldn't be looking at sleep apnea in isolation, but in conjunction with other lifestyle factors that not only influence cardiovascular disease, but may interact with sleep apnea-related stresses. Now, the second example is an example of genetics performed by my postdoc, Matthew Goodman, who really asked the question, or really made the observation, that we know there are multiple genes that increase cardiovascular disease, and many of them are very responsive to hypoxia. And in order to get power, he created what was called a pathway-specific polygenic risk factor for 4 pathways that included various combinations of hypoxia-sensitive genes, and then used data on 500,000 people from the UK Biobank to test whether you have sleep apnea or not actually moderates the extent to which these genetic risk factors predict your likelihood of getting a myocardial infarction. And what he found in work that's in press right now is that individuals that inherit, have genes enriched with VEGF, vascular endothelial growth factor, risk factors, who have sleep apnea are actually relatively protected from coronary artery disease. What that means is, in the absence of sleep apnea, these risk factors increase coronary artery disease. But in the presence of sleep apnea, maybe mild to moderate hypoxia, these genes may operate in a way that may promote angiogenesis and protect these outcomes. And finally, I like to just also really acknowledge that one of the big blind spots we have when we study the relationship of sleep apnea and cardiovascular disease is we have no idea how long most of our patients have had sleep apnea before they've been treated. And in fact, that we postulated that, in fact, in the Sleep Heart Health study, one of the reasons for the initial null findings in women when we looked at AHI relationships and then 6-year rates of cardiovascular disease was that, in fact, women do tend to get sleep apnea at a later point in life. And then if you study them with PhDs, say in Sleep Heart Health, it was a mean age of 62, and only follow them for a few years, that exposure for just a few years may not have been sufficient to stimulate those atherogenic processes that may lead to cardiovascular disease. And that hypothesis, to some extent, may have been supported by further follow-up we did in Sleep Heart Health study, where we had one sub-cohort, which was studied now for 13 years. And when we studied the cohort, the same cohort with additional years of follow-up, we found that untreated sleep apnea in women was predicted a 26% increased risk of heart failure or death. It was also similarly associated in women, and actually not men, with left ventricular hypertrophy, a marker for heart failure and death. And in fact, blood work done at the time of the polysomnogram for high-sensitivity troponin, a marker of subclinical myocardial injury, actually was elevated at the time of the PSG and increased progressively, as you could see in these pink colors, with increasing severity of sleep apnea. And that occurred in women than not men. And that really, really just emphasizes, again, sort of the idea that we have to be very humble in recognizing the limitations of our knowledge and recognize that cumulative exposures may also be quite important. So in summary, I've tried to review a very complicated topic, but I'd like to suggest that there are the emerging metrics of disease that may better identify patients at risk for cardiovascular-related, sleep apnea-related cardiovascular disease. This includes utilizing information from these mechanistic endotypes, physiologic response markers like delta heart rate, as well as incorporating measures from multi-omic analyses. There's this potential for using more data like this and applying machine learning and emphasizing the need for sex-specific considerations. I also hope you appreciated the need for multidisciplinary teamwork. So how do we move ahead? So I think as we think about that AHRQ challenge, we clearly need larger and longer studies that are better designed. We do need to enrich the sample, and perhaps markers such as hypoxic burden and heart rate response may be reasonable ways to get samples likely to respond to CPAP. We also need designs that aren't just fix people to sham or CPAP, but allow adaptation over time, because I think I've tried to emphasize sleep apnea may not be one disease, and even with those endotypes, we may not fully appreciate what the initial best strategy may be, but we may need to serially test. And I think, again, we also need to know that our key partners are patients. And in order to design trials that patients will accept and embrace and will be successful, we need to materially engage them in study design. And even clinically, we need to engage them in shared decision-making. So in conclusion, in responding to the AHRQ report, I'm not upset by this report. I think it is, I don't agree with everything in the report, but I think there is a call to action in our field. I think we have the need, the opportunity, the tools, and the wherewithal to improve our case identification, use better metrics, incorporate mediators of disease in our thinking, and with NIH's help and maybe industry's help, identify better studies. So I'd like to conclude by acknowledging all the cohorts that I've worked with and the amazing people in physiology, engineering, genetics, epidemiology, all of our staff and our patient partners. And thank you very much for your time and privilege to talk.